Welcome to our video on acute appendicitis. Let's begin. In this lecture, we'll discuss definition, etiology, pathophysiology, clinical presentation, diagnosis, management, and complications of acute appendicitis. On this slide, we have an algorithm that will help integrate the high-yield concepts you need to know about acute appendicitis. We will see this algorithm again at the end of this lecture. Hopefully, this algorithm will serve as a guide in mastering this topic. Acute appendicitis is caused by an obstruction of the appendiceal lumen. This obstruction causes stasis within the lumen, eventually leading to inflammation of the appendix. We will discuss this further on the pathophysiology section. Complications of this disease can result in a surgical emergency, thus requiring prompt treatment. This disease is typically seen in patients in their early teens or middle-aged adults. Let's discuss common etiologies that can obstruct the appendiceal lumen. Hyperplasia of lymphoid tissue is often seen in children, which can be physiologic or due to infectious causes. On the other hand, a fecalith is a more common cause of obstruction in adults. Other etiologies of obstruction of the appendiceal lumen include foreign bodies and parasites. Let's talk about pathophysiology of appendicitis. Remember the concept from step 1 that whenever there is obstruction in a tube, there is a high risk of infection behind it. First, there is accumulation of bacteria in the appendiceal lumen due to stasis. This results in a distended appendix and subsequently increased intraluminal pressure, exceeding the venous pressure, causing vascular congestion. As a result, vascular supply is compromised. When the lumen receives less blood supply than normal, ischemia may follow. Finally, the appendiceal wall weakens and complications like perforation can occur. Let's take a look at an illustration on the next slide to help emphasize some of these points. The presence of a fecalith in the lumen causes obstruction, leading to bacterial growth. Also, there is an increase in the intraluminal pressure, which stimulates the visceral nerves. This gives the classic presentation of acute appendicitis, which is a right lower quadrant pain. Let's talk about different locations of the appendix. The most common location of the appendix is retrocecal, followed by the pelvic area. There are other locations where we may see the appendix, which include subcecal, pre-ileal, and post-ileal regions, but these are relatively rare. Location is very important because clinical presentation can vary according to it. How can a parasitic infection result in an abdominal abscess in the retrocecal area? As discussed on the previous slide, the most common site of appendicitis is retrocecal, so this question is simply asking how a parasite can lead to an abscess in the setting of appendicitis. Let's not confuse this with pseudoappendicitis, which we'll discuss later. A parasite can become so large that the worm itself is the cause of obstruction. The pathophysiology is then similar to the process of a fecalith causing an obstruction. The obstruction leads to distension of the appendix and increased intraluminal pressure. The venous system pressure is lower, leading to vascular congestion and a compromised vascular supply. Ischemia then follows, and if left untreated, there is a weakening of the wall resulting in perforation. Then an abscess can form if perforation is contained within the omentum. Now let's discuss clinical features. Nonspecific symptoms include anorexia, nausea, vomiting, and fever. Diarrhea or constipation are also common manifestations. Diffuse and dull periumbilical pain is present initially as a referred pain from activation of visceral afferent neurons of appendix. Due to further distension, the parietal peritoneum becomes irritated, leading to a localized sharp right lower quadrant pain in the location known as McBurney's point. Here are some useful signs that help in diagnosis. First is pain at McBurney's point, which is 2/3 of the distance from the umbilicus to the right anterior superior iliac spine. Roving sign is right lower quadrant pain upon palpation of the left lower quadrant. SOAS sign is right lower quadrant pain when the right thigh is extended. Finally, obturator sign is right lower quadrant pain when the right thigh is flexed and internally rotated. For a visual picture, let's discuss the classic term used when describing the location of pain in acute appendicitis. In the image above, focus on the dotted black line between the umbilicus and the anterior superior iliac spine. This is called McBurney's point. It is 2/3 of the distance from the umbilicus to the right anterior superior iliac spine. Tenderness due to acute appendicitis is often localized in this region. Let's discuss another popular sign that can aid in diagnosing acute appendicitis. Palpating the left lower quadrant is a useful technique. When pain is elicited in the right lower quadrant upon palpation, this is a positive roving sign. Although these signs are not highly sensitive, They are helpful in directing us to the diagnosis. Let's discuss another sign that can aid in diagnosing acute appendicitis. On physical exam, we instruct the patient to lay on the left side, and passively we extend the right thigh in the direction of the red arrow, just like the image above, while applying counter resistance to the right hip, which is marked by a green asterisk. When pain is elicited in the right lower quadrant, this is a positive psoas sign. Remember that these signs are not highly sensitive, but they are helpful in directing us to our diagnosis. Let's discuss another sign. During a physical exam, the right hip and knee are flexed. While maintaining this position, the patient's right lower leg is moved laterally, marked by blue arrow, applying counterforce at lateral right knee, resulting in internal rotation of the hip, marked by a red arrow. If this elicits pain in the right lower quadrant, it is a positive obturator sign. Remember that these signs are not highly sensitive, but can be helpful. It is important to differentiate the clinical features of acute appendicitis and a disease that can present similar to it. Pseudoappendicitis often presents like appendicitis, but with bloody diarrhea. The classic cause is Yersinia enterocolitica, a gram-negative bacteria. Although self-limited, it may be fatal in immunocompromised patients. Therefore, it is treated with doxycycline in patients who are immunocompromised. Acute appendicitis can be diagnosed clinically. The Alvarado scoring system is often used by the clinician, which we will discuss on the next slide. When a female patient comes into the ER with abdominal pain, a beta-HCG pregnancy test is done to rule out ectopic pregnancy, as it is one of the most common causes of abdominal pain in a female of reproductive age. Laboratory findings may reveal leukocytosis with a left shift and immature white cells called band cells due to ongoing inflammation. Increased C-reactive protein may also be present. Lastly, urinalysis can present with mild pyuria due to appendiceal inflammation irritating the ureter or bladder. The Alvarado score was developed to assist physicians in diagnosing acute appendicitis. A score of 5 out of 10 confirms the diagnosis. Let's discuss clinical features that are useful in scoring. Migration of pain, anorexia, nausea, rebound pain, elevated temperature, and shift of white blood cells to the left each score a point in the scoring system. Additionally, tenderness in the right lower quadrant and leukocytosis each receive 2 points in the scoring system. The mnemonic Mantrels is helpful in recognizing the clinical features in the Alvarado scoring system. Here, a score of 0 to 3 is unlikely to be appendicitis, and a score of 4 and above is further evaluated to rule in or rule out appendicitis. When a clinical picture is equivocal, 2 imaging studies can be used when there is a high suspicion of acute appendicitis. First, a CT scan with PO and IV contrast may reveal an enlarged appendix, usually greater than 6 millimeters. A fecalith with perappendiceal fat stranding and free fluid confirm diagnosis. On the other hand, ultrasound is best for children and pregnant women. Ultrasound can also show evidence of an enlarged appendix as well as peritoneal fluid or abscess in more advanced cases. On this slide, we're looking at a CT scan with IV contrast of a perforated appendix. Notice the green circle. Edema has a lucent or dark grayish appearance on CT scan. Here we can then conclude the appendix is surrounded by edema. Like previously mentioned, a fecalith is a common cause of appendicitis. Notice the white bean-like pattern on the image above. Presence of a fecalith confirms the diagnosis of appendicitis. Moreover, there is suspicion of perforation just by looking at the extraluminal air pointed out by the red arrow, as well as intestinal gas. As we will learn, evidence of perforation is a surgical emergency, and this patient must be treated immediately. In this slide, we're looking at an ultrasound of the abdomen with evidence of appendicitis. Let's go through this image carefully so that we are prepared for images such as this during the exam. Notice the yellow circle. This yellow circle is the appendix. We will be discussing the layers of the appendix one by one so we can better understand the inflammatory process and how to confirm the diagnosis. This is the serosa. Here we have the muscularis. This layer appears hypoechoic or a dark grayish appearance suggesting edema formation. Then we have the submucosa. The submucosa is hyperechoic, giving off a lighter appearance, indicating an inflammatory process. Lastly, we have the lumen. Remember that ultrasound is the preferred imaging modality to diagnose acute appendicitis when a patient is pregnant or the patient is a child to avoid contrast toxicity and unwanted radiation exposure. A 17-year-old obese female presents with 2 days of right lower quadrant abdominal pain that started at her belly button. What diagnosis should you consider with this presentation? Is any imaging warranted in this patient? The patient is presenting with concerns of appendicitis, especially due to the location of the pain and age of the patient. But before we start treatment of appendicitis, we need to rule out other life-threatening conditions. Ectopic pregnancy cannot be ruled out just by the history, so a urine pregnancy test must be done prior to imaging. If a question describes a female patient with lower quadrant pain, a pregnancy test is always performed before ultrasound or CT scan to rule out ectopic pregnancy. Then, if imaging is required, ultrasound is preferred for pregnant patients and children due to the contrast toxicity and radiation exposure that CT scans have. Here, ultrasound would be the preferred imaging. These concepts should be very clear to you when you work up a suspected appendicitis. Let's talk about management of appendicitis. The standard treatment for acute appendicitis is an urgent open or laparoscopic appendectomy. However, keep in mind that supportive management is initiated as soon as possible. Patients must be kept NPO and should be given intravenous fluids as well as antiemetics. Because of bacterial colonization, a single dose of antibiotics that cover anaerobic and gram-negative bacteria is given. This is given for all patients with acute appendicitis. However, patients with non-perforated appendicitis should not require antibiotics for more than 24 hours. There are several complications that can occur following acute appendicitis. We will discuss a perforated appendix, abscess formation, gangrenous appendicitis, inflammatory appendiceal mass, and pylophlebitis in the upcoming slides. The most common complication in acute appendicitis is a perforated appendix. Free rupture of the appendix is a surgical emergency. When a patient arrives with symptoms of appendicitis along with high fever, tachycardia, hypotension, rebound tenderness, guarding, and decreased bowel sounds, there should be concern for a perforated appendix. Emergency appendectomy is the definitive treatment. Perforation also requires the use of intravenous empiric antibiotic. When cultures are obtained, an appropriate antibiotic can be used to narrow coverage. Antibiotics are given for 3 to 5 days with frequent monitoring of white blood cell count for treatment efficiency. Appendiceal abscess formation is also a common complication. When there is an inflamed appendix, pus and necrotic tissue surround the area leading to abscess formation. High-grade fever and leukocytosis, along with symptoms of acute appendicitis such as localized right lower quadrant pain and tenderness, may be present on physical exam. Imaging may reveal a fluid collection surrounding the appendix. Although symptoms are similar to a perforated appendix, the management is different. An abscess greater than 4 centimeters must be drained before performing elective appendectomy 6 to 8 weeks later. However, abscesses less than 4 centimeters can be treated with antibiotics alone. Next, we will be discussing gangrenous appendicitis. Vascular thrombosis and mucosal ulceration is the most common cause of gangrenous appendicitis. Necrosis of the appendiceal wall in the setting of transmural inflammation progresses to form gangrene. It typically is diagnosed intraoperatively. The symptoms are similar to complicated appendicitis, which include high-grade fever, tachycardia, and tenderness. Definitive treatment is also similar in that an emergency appendectomy is performed and intravenous antibiotics are given. Patients with acute appendicitis can present with an inflammatory appendiceal mass. It is described as an ill-defined mass of inflammatory periappendiceal tissue. On physical exam, a tender mass localized in the right lower quadrant may be felt upon palpation. For this, administration of IV antibiotics is often the primary treatment along with supportive management. Surgery is planned if patient's condition does not improve after 48 hours of antibiotics. The last complication we'll be discussing is pylophlebitis. It occurs in the setting of septic thrombosis of the portal vein or its branches. Bowel infarction may emerge and eventually lead to death. It occurs as a sequelae of the spread of intra-abdominal infection from perforated appendicitis, diverticulitis, or other infections. Symptoms usually involve fever and abdominal pain. Here, patients are managed with broad-spectrum antibiotics. In this slide, we can review the algorithm that was introduced earlier in the lecture. We begin with a patient with signs and symptoms of appendicitis such as anorexia, nausea, vomiting, right lower quadrant pain, or rigidity with an acute onset. History and physical exam, along with revealing laboratory findings on CBC, are useful in the diagnosis of the disease. The classic presentation on history and physical exam are often including migrating pain starting in the periumbilical region, migrating to the McBurney point in the right lower quadrant. The patient may also have a positive Roving's, psoas, and or obturator signs. Laboratory findings typically reveal evidence of leukocytosis. Gender also plays a role in the diagnosis of acute appendicitis. Females with similar symptoms must receive a pregnancy test in order to rule out pregnancy. If the patient is pregnant, abdominal ultrasound is used as the initial imaging method. Finding of an enlarged appendix on imaging confirms the diagnosis of appendicitis. Patients are managed with IV fluids and are kept NPO. They are also given analgesics and antibiotics. Definitive management is an appendectomy. Patients without the classic presentation of appendicitis are further investigated. If the clinical presentation is equivocal, without bloody diarrhea, abdominal CT is performed unless they're pregnant. An enlarged appendix confirms the diagnosis. If episodes of bloody diarrhea are part of the patient's history, pseudoappendicitis is suspected. Thus, supportive management is followed in addition to doxycycline for immunocompromised patients. A 27-year-old man presents to the ED with complaints of abdominal pain for 6 days, accompanied by anorexia, nausea, and vomiting. On physical exam, his blood pressure was measured to be 90/60, pulse of 90, and regular in rhythm. There is localized pain and tenderness in his right lower quadrant. Family history is unremarkable. The patient does not smoke or drink. The CT scan demonstrates a 3 centimeter retrocecal, well-defined fluid collection. Which of the following is the next best step in management after IV fluid bolus? A. Urgent laparotomy. B. Proton pump inhibitors. C. Intravenous antibiotics. D. Analgesics. In this question, our patient presents with abdominal pain for almost a week. He is hypotensive and tachycardic. On physical exam, there is pain in his right lower quadrant, which hints at appendicitis as a potential diagnosis. CT scan is suspicious for abscess formation due to the defined retrocecal fluid collection. In cases of appendiceal abscesses, IV antibiotics are indicated over surgery, making C the correct answer. However, it's important to remember that he should be stabilized from the standpoint of his hypotension first, which is why antibiotics would be given after an IV fluid bolus. Remember that an appendiceal abscess must first be managed with IV antibiotics if it is less than 4 centimeters in size, and drained percutaneously if the abscess is larger than 4 centimeters. Morbidity and mortality is lower with this approach than with immediate surgery. Urgent laparotomy is needed to prevent perforation, but since perforation has already occurred and resulted in abscess formation, IV antibiotics are indicated, making A incorrect. Answer choice B, proton pump inhibitor, is the mainstay treatment for acute gastritis and peptic ulcer disease. Although analgesics are given for pain management, the underlying condition needs to be addressed, so D is incorrect. Analgesics will be given, but IV antibiotics ultimately lowers the morbidity rate in patients with abscess formation from appendiceal rupture and will be the next best step in this case. And this concludes our section on acute appendicitis.